Thank you for inviting me to give this talk. I know my introduction slide looked very busy, but basically I'm a professor at George Washington University in Washington, DC, and I work on stem cells and precision medicine in diabetes. So without further ado, so essentially we are going to talk about how we can use a prediction model for clinical decision making using gut microbiome. So precision medicine is essentially when a person, for example, is fairly new, but for an example, a person, let's say, needs a blood transfusion and he is trying to match the blood type to the recipient to reduce the risk of complications. So in other words, how can we predict a transfusion that is not going to go wrong and just catered to an individual person, and what would work best for that particular person? And right now, our medicine is not so-called geared towards an individual person. It's based on large data sets, which does not always preclude to a singular person and their disease, mortality, and morbidity. So essentially, the prime components of precision medicine right now is how does lifestyle and environment influence a person's disease. So that's why it's important as a so-called preventive medicine step. So the goals of precision medicine are to predict, prevent, and treat a disease. And it's actually very important for a metabolic disease, which, as you know, goes on for a significant period of time and then manifests at a later stage. For example, diabetes is, we call the iceberg phenomena, right? So precision medicine is an emerging approach to a disease treatment, including various components such as the genes, environment, and lifestyle of each person. So it actually is beyond what we call just genes or epigenetics. It also includes lifestyle and, for example, diet, exercise, etc. So here is a schema which talks about how we integrate all these different information pieces. So we have information inflow coming from direct volunteers, and then we integrate their data into a data set, right? And then we upload it to a cloud with the identification taken out. And we try to get all the data from different biological samples in order to also have influence from the clinicians and then get an output from the information flow out. Now, I know this is not very clear right now, but let me explain a bit more. So the various data sources at the moment we have is a self-reported measures such as diet, activity, so on. Then you have the vitals that you would get done in a physician's office. And then comes the so-called coding of various diseases that a person has. So that, and that's why coding for a particular disease is so very important. And now every healthcare system in the United States would insist about appropriate coding, because that's how you build a data set. Then comes the so-called different biospecimens, for example, blood, fat, stem cells from blood and fat, and ultimately stool microbiome, right? So you have to, if you think about it, you have to identify which is your primary outcome and where do you put your most of your statistical prediction on. So if you talk about genes, epigenetics or environment, and one's lifestyle, this stool microbiome almost involves all these components or has a reflection from all these components. So this has been talked about, precision medicine, way back in our meeting at diabetes or ADA in 2020, when it was talked about as precision diagnostics In other words, taking into epidemiological evaluation, probability, and diagnostic testing. So precision diagnostics is number 1 point. I'm just introducing some terms right now. Then comes the precision therapeutics. In other words, you take into account what interventions can you possibly do. Let's say prediabetes, which, as you know, in the United States, we have 80 million people with prediabetes, and I'm sure, which is about 1/4 of the population. And I'm sure the statistics won't be that different in India either. So you have various therapeutic interventions, starting from lifestyle to therapy. And then you have prognostics, which includes various complications of the disease, such as cerebrovascular retinopathy, cardiovascular, and so on. So you have to actually integrate, as you have been listening to different talks, that what medications work for different complications. And clearly, there's not a singular answer to that. In certain conditions, such as nephropathy, SGLT2 may be better. In cardiovascular, you might have a GLP-1 working better, but how do you integrate one person's lifestyle, food items, to all of these interventions? So as you can imagine, it's a huge data set that we have to integrate to individualize and decide what medication would work for that particular person. So the path to precision diabetes medication involves a lot of data collection and integration. And then ideally, it should have a format where a clinician can input these data and get a science-based prediction. Right now, as a clinician, when all of us sit in front of a patient, it's based on certain parameters of large-scale clinical trials, which may not have anything to do with that particular person sitting in front of you. So we need so it almost becomes an eeny, meeny, miny, mo business. So instead of that, you need some form of science, and that's what the precision medicine or prediction medicine is trying to do, to individualize therapy. So here comes the gut microbiome. Why do we think gut microbiome may be a novel diagnostic tool towards precision medicine? Because the gut microbiome essentially is a collection of various organisms in the ecosystem, right? It's a collection of genes in the microbiomes and influences from the environment, meaning influence from the diet, from the lifestyle, and so on. So it has certain components, particularly metagenomics, which is the genomics part of the microbiome. To that, you can add so-called metabolomics, which you can get from the, let's say, serum, right? So essentially, you are trying to integrate metagenomics, transcriptomics, and metabolomics. I know these words are bombastic, but let's kind of bring it down to so-called genomics from a stool flora, metabolomics from serum, and you're trying to integrate all of this along with the history of the patient. So the gut microbiome, environment and host interaction is actually important, and we have recognized this several decades back. But the microbiome is the primary filter for a large environmental exposure such as food, right? So essentially, we are what we eat. It's the largest endocrine organ, which is the gut, and possibly the most efficient metabolic machinery. It generates various useful metabolites, also toxic products, which are detoxified by the bacteria in a physiological state. So it's in a constant flux. In fact, it's every day that flux or the biome changes based on what you have done or what you're about to eat. So the gut microbiome and the health, it integrates, it controls the digestive function, it generates the metabolic products, degrades dietary oxalates, and so on and so forth. And of course, it has an influence on your drug metabolism. So all of these, if you think about it, is way more individualized than what you can get from serum or urine per se. So this was actually recognized by our predecessors in medicine way back in before Christ, that the death sits in the bowels and bad digestion is the root of all evils. So it's essentially revisiting what we knew for 2000 years. Qualitative and quantitative changes in the gut flora and its distribution would change, and gut dysbiosis is actually an important topic. So why dysbiosis in metabolic disease? It has an influence on the gut from various components. I'm not going to talk of individually all of this, but I think all of you know most of this to begin with. So let's talk about very basic topics, for example, that is already in textbooks right now. So some of the endocrinologists in the United States have certified in so-called obesity medicine. As you know, this is primarily a diet-based issue along with lifestyle. So this is almost part and parcel of that course, which means if you have a higher ratio of firmicutes to bacteroides, your chance of getting cardiovascular disease is way higher. So this is something we know. And this took us several years to consolidate this data, right? So how can we build on this very simple data that we have here to better prediction to, let's say, a particular diet, such as Mediterranean diet, ketogenic diet, and so on and so forth. We also know about from 10 years back that various items, for example, red meat, carnitine, etc., promotes atherosclerosis. Now, this wasn't actually linked to Firmicutes and bacteroides, but it actually was linked to certain flora within the gut, right? Then we also have so-called microbiome therapy, where we can treat a specific microbiome and restore the dysfunction. So, such as prebiotics are non-digestible food items that are used to restore a particular flora, which can subsequently change your metabolism. And then we have so-called microbiome engineering, where you have a signal transduction from an environment, signal, then you propagate that, and you can engineer a specific microbiome to improve your metabolic health per se. So let's come to our study, what we are trying to do, because I don't want to take you too further into microbiome, which is a whole different topic itself. I'm sure somebody has covered it in these sessions. But what we are trying to do is to try to identify what lifestyle would work for veterans. So this is a US federal government mandated study. We have, as you know, a significant amount of patients, 88 million Americans have prediabetes. And how can we predict whether a certain food item, for example, low-calorie ketogenic diet, can change the gut microbiome, and is it even worthwhile for a certain number of people? So what we plan to do is to use a machine learning database application and to discern signals from the gut microbiome, utilizing gut genomics, serum metabolomics, and even urine microbiomes and urine flora. And we are going to target primarily A1C of 5.7 to 6.4, because diabetes prevention program and other studies have shown that lifestyle changes do help, but obviously not everybody. And that's why we are trying to individualize who would benefit. And as you can imagine, when a patient walks in with prediabetes, we often tell them go and do lifestyle intervention. But that means they have lost 2 years of their life in this process. And then the next time they come to you, if they haven't responded, they're full-fledged diabetic or very close to it. So you have actually lost not only time, but their precious health. And this goes on and on. It doesn't just stop from pre-diabetes to diabetes. It goes on even when they have diabetes. So our secondary objective is to corroborate all these data from gut microbiome along with other studies that we know have been shown to have strong biomarkers such as serum-based, serum endothelial inflammatory markers, appetite-controlling hormones, renal function, and so on. So as you can imagine, all these are linked, but we have not yet developed a database which is primarily based on pre-diabetes subjects. And our study hypothesis essentially is to use the gut microbiome and the metadata used from this study with a short intervention of 3 months to see what changes in a short ketogenic diet intervention. Now, ketogenic diet is actually interesting in the sense that within 1 month, it can change the gut microbiome. So 3 months actually is quite enough to show those changes. So we are going to put it in a database that we have developed along with the federal government. This has several $1 billion have gone into it. And our aim is to ultimately apply this predict mode machine for clinical use. And our projected time is about 3 years down the road. So we have a clinician like me with a lab along with bioinformatics, which is also from one of my colleagues at GW, who is Dr. Mazumdar, who is actually a graduate from Calcutta as well, but he has done significant amount of work on database development in medicine. As I said, we are going to develop these various steps. I'm not going to read through it, but our future considerations is to go into not just pre-diabetes, but other disease models as well. We have already published some data on COVID and projection of COVID from our databases. So we are also trying to identify the appropriate patients, not just veterans, but beyond veterans, getting the fetal microbiome data, statistics, and response. The good thing about why this is based in the VA system is because the VA system is integrated throughout the country. And we have data from all the VAs across the 50 states. So that's why the statistics is actually enormous on all these patients. There's obviously a huge amount of advantage in doing using the database that we have along with the microgenomics that we're going to apply. And of course, as I said, the potential is quite large going forward. So in summary, we have a human host and gut microbiome that is interdependent. It's inflammation-based and CVD-based. We have already some data on it. And in summary, we would like to emphasize that utilizing the gut microbiome metagenomics along with the metabolomics to develop a prediction model to determine how an intervention as simple as ketogenic diet can be effective without wasting time, fund, and metabolic health. Thank you so much. And these are my fundings, my group, and I'm happy to take any question.